Hi, this is Dr. Anuj Shah, and today I want to talk about diabetic foot ulcers. And when your ulcers don't heal, what does that mean? And what do we need to do to make sure these ulcers heal? Right? I'm the director of Apex Heart and Vascular. I'm trained at Mount Sinai Medical Center in New York City, and I work at several hospitals in New Jersey. I don't have any disclosure for this presentation. So when the ulcers don't heal, it's a big problem. So we're going to start with this case. This was a 45-year-old woman who had diabetes, morbid obesity, and she came to us with this painful second toe. This ulcer is ischemic and very painful. And why is it not healing for almost several months? Because she had severe blockage, as you can imagine, from her risk factors in the underlying artery. So you see that this is her superficial femoral artery that completely clogs up where the yellow arrow is, which is the popliteal artery. And then further distally, it reconstitutes with collaterals, which is the natural bypass, but it's not enough to improve the blood flow to the foot. And this, the final picture shows after fixing what it looked like. So let's again take a look. This is the artery before, this is the artery after. So I'm going to draw this so you understand what it looks like. So when the arteries come down like this, oftentimes they have inside, they get complete blockage. This whole thing is completely clogged. And the reason the blood still flows there is because body forms what we call natural bypass or collateral, which has these tiny squiggly lines that feeds the leg. But you have to imagine that this is the national highway, which is completely clogged, and now we are trying to go, all the traffic is trying to go through small detours. It doesn't really work and doesn't help. So what we do is we pass a wire, and the wire goes through this blockage, and then we open it up with either atherectomy or balloon or stent and reestablish the blood vessel looking like this. So pretty much that's what you are seeing on the screen is a completely clogged artery and after fixing it. And what happens when we fix the blockage? The ulcer and the wound actually now gets blood flow and it starts healing. So it's a pretty common problem. Peripheral vascular disease is as common as 20% population over age of 70 has some form of peripheral arterial disease, right? Almost more than 20 million United States individual has some form of PAD. It's very common when people have diabetes, hypertension, high cholesterol, and smoking, the big ones. When somebody has diabetes and smoking, I almost guarantee they have some form, some degree of PAD. Part of the problem with PAD is detection is not that easy because not everyone gets the classic symptoms. The classic symptom is severe pain in one muscle group of the leg when they walk, and it gets better when people stop walking. Unfortunately, for most people, these symptoms are not present. So they have atypical symptoms. It's why it's easy to miss. Sometimes people miss it, patients miss it, sometimes doctors miss it. Rate of exam in doctor's office is not that great. Less than 5% of primary care doctors even check people's pulses. Less than 10% of the cardiologists check people's pulses. The rate of taking shoes and socks off in a doctor's office is less than 1%. So no wonder PAD gets missed. But then why is it so crucial to look for peripheral arterial disease? Because it's a pretty big problem. When people get ulcers, when they have leg pain, it's excruciating. They pretty much have functional loss of their lives because they can't really walk. We always think of amputation causing limb loss, but there is also a concept of limb loss without amputation or the functional limb loss. And if you miss peripheral arterial disease, you will actually miss cardiac disease because peripheral arterial disease people have the same risk factor and they have the same kind of mortality that somebody who already had a heart attack or somebody who already had stroke. Amputation itself, it's a pretty big deal, right? Most people who get amputation at one level will continue to get amputation at a higher level. A person who loses the right toe is the same person who's going to get higher risk of getting right foot amputation at the ankle level, then at the knee level, and at the thigh level. And then the same person is also at risk of getting amputation now on the left leg. And they enter this downward spiral where they keep losing their legs, different degree, and then they are dependent on others. Oftentimes they end up in nursing homes or require prolonged hospitalization and catch nosocomial infection. They get ulcers on their sacrum, the decubitus ulcer, which causes them more sick, gets pneumonia. Once people get amputation, they get so many other comorbidities with it that their overall survival really gets truncated. And that's why amputation is as bad as getting a cancer. The mortality after amputation is worse than getting most of the cancers. That's why we have an ethical responsibility to pick up people who are at risk of amputation and do limb salvage. We also have a medical legal responsibility because if somebody has PAD, which is a reversible issue, and it gets missed, and somebody ends up amputation, that's not good. And finally, cost. We live in an era where cost is everything. 25% reduction in amputation will save $3 billion in healthcare money. Total estimated cost of peripheral arterial disease is between 150 to 300 billion dollars, more than even coronary artery disease and stroke patients. When people get amputation, their mortality in-house for below knee is 5 to 10%, for above knee is 20%. 1 in 5 people who will get above knee amputation in the hospital will not make out of the hospital. Nursing home care after amputation is also very high, $100,000 per patient per year. A lot of reason why amputation is bad, and we really need to salvage people. So this is when we need to recognize people who have critical limb ischemia or CLI. Around 1.5 to 2 million people with PAD will form CLI. CLI is pretty bad. Amputation occurs in 10% of the CLI patient. Once you have CLI, 25% will die with 1 year onset of CLI, and 25% will end up having some kind of amputation. 40% of them will die within 2 years. So what really helps in these people is something called outflow, right? And I'm going to draw and explain to you what an outflow is, but it's basically excellent blood flowing all the way to the foot. When you establish outflow, you're actually causing limb salvage. You are actually improving their likelihood that these wounds will heal and they will not get amputation. But on top of that, improving outflow also improves survival. That's why when somebody comes in with a non-healing wound or an ulcer, it's important to improve the blood flow because it improves survival in addition to protecting people from amputation. So this picture actually nicely shows what a normal tibial artery should be, right? So this is the popliteal artery that goes and trifurcates into 3 arteries. Artery that goes in the, so I'm going to draw it here. So when we look at the legs, this is, oh, can you see it? Okay. So this is the aorta, which is the main artery in the leg that bifurcates. I'm going to draw the leg, which is here. Pardon my drawing. This is the leg. You can see this. So these are the legs, and this is the main artery aorta. Aorta then bifurcates into both iliac arteries. When you get the thigh level, it goes into SFA, that goes in the front, and profunda that goes in the back, and then becomes popliteal, and it divides into 3 arteries. Anterior tibial goes in the front, tibioperoneal trunk, which bifurcates into peroneal that goes in the back, and then posterior that goes in the back of the foot. I'm going to draw the tibial vessel a little bit better here so we can get a better understanding of the outflow. When we look at the tibial vessel further lower, it kind of looks like this. So anterior tibial artery comes like this, tibioperoneal trunk, peroneal tibial artery, and posterior tibial artery. You can see here. This posterior tibial artery then bifurcates into lateral and medial plantar branches in the foot, and then the anterior tibial artery gives rise to dorsalis pedis artery, and they form something called a pedal loop. Pedal loop is then what's going to feed all the toe blood vessels. It's going to basically feed all these toe blood vessels and going to actually help with keeping the wound intact and the blood flow to the wound. It also feeds the calcaneum, which is back of the foot. So that's why integrity of this pedal loop and all these 3 tibial vessels is very important. You can see in this picture right here, you can see 3 tibial vessels are beautiful, wide and open. And when you look at the foot level, it forms this beautiful loop, as I showed you here, which helps. Unfortunately, most of our patients, when they have these wounds, it looks something like this, that they have occlusion, either in the proximal segment or in the distal segment. How we went from the tibial artery, anterior tibial artery, we try to open the blockage. I'm going to show it here actually. So this particular case, patient had a blockage in the, I'm going to show this video separately. But this was the blockage in the anterior tibial artery, and the patient had a wound in this part of the leg, right around here. So if this artery is completely blocked, this is not getting any blood flow. So what we initially tried is to try to open the blockage going in this direction, but no luck. So then we actually stuck the foot here at the anterior tibial distally and went up, what we call the pedal stick approach, or TAMI approach, what we call, and actually help open the blockage. Not only that, after that we passed a wire that went through this. We also opened the posterior tibial artery because this was also blocked. So it's a great video that actually demonstrates how this artery is working. So you can see that we now
the vessel is heavily calcified, and it's very difficult to go and cross the distal cap of the total occlusion. The other two vessels is also diseased, but AT is really the angiosome-related artery with the main blockage. So what we do in these cases is we get access into here. The dorsalis space, which is here, where the vessel is reconstituted, and try to go up. So you will see the case where this is all the tries of going antegrade. First of all, the balloon could not pass. So as a retrograde puncture, we do dorsalis pedis and pass the wire, which goes back up, and we do what we call rendezvous, which means like meeting of a wire from the bottom and wire from the top. And when the two wires meet each other, we balloon it when we try to break the plane.
So one wire comes from the top, one comes the bottom, and we balloon it to break the plane, and the blockage nicely opens up.
And once we cross the whole thing, we snare the wire up from the sheath. So now the wire that was going from the top.
So you will see this way, we actually reestablish the flow. This is the ballooning of the, you will see anterior tibial artery looks beautiful. But then on top of that, we would go ahead and we also take advantage of the pedal loop and open the posterior tibial and the lateral plantar artery.
And we can cross the pedal loop and we can get the lateral plantar access and get access from the other way. So this is the wire going from anterior tibial artery going down through the lateral plantar artery, and the wires going here, and then we pass another wire from the top, and we complete the pedal loop. Pedal loop is the single most important thing that feeds all the digital blood vessels as well as the calcaneum, and is responsible in healing of these wounds.
So you can see at the end, last picture, if it plays, but it's a beautiful blood flow, pretty much what you would expect in a normal. All three vessels are reestablished, as you can see here. Good result. These are some of the novel techniques that we apply. This is another case, 61-year-old woman who has multiple risk factor and has this really nasty looking wounds and ulcer, which have not been healing for a while. When we look from inside, SFA blockage. Patient also had below-knee blockages. After fixing the blockage 6 months later, the wound looks beautiful with a nice, we love seeing the granulation tissue, which means it's gonna heal properly. This is a 91-year-old woman who had this really bad, painful ulcer. She had prior history of stroke. The recommendation is just amputate the leg, otherwise she was gonna get septic. Fortunately, when we looked at it, she had complete occluded SFA. Popliteal was open, but then below knee, again, severe blockage. Fortunately, we could pass the wires and balloon, then we established one vessel runoff in this lady. And 3 months later, after plaque excision, she did not require any skin graft. She did not require any prosthesis. She did not even require any pain medication. So some amazing result. Endovascular obviously works amazing. The lower limb bypass surgery is still an option. The problem with bypass surgery is it does not come without any risk. There is anywhere from 1.9 to 3.4% mortality and heart attacks that happen while people go through bypass, and up to 6% people can die. There's also a higher risk of wound infections, from 10 to 30%. Some people get scar-related neuropathic pain. The problem with bypass most of the time is not having conduit. People, to bypass, you need like a vein or something that you can use. And most of these people, they don't have good veins. So they require Gore-Tex or PTFE graft. They don't really last that long. Below knee bypass grafts also don't last too long. And oftentimes they don't have any healthy vessel left to go and take that suture. So bypass has its own set of limitation that comes in. And that's why endovascular treatment has really taken over. This is another video of showing metal in blue. I'm going to put it later because it's a pretty long video as well. So in conclusion, PAD is a very prevalent disease entity with widespread impact on mortality, morbidity. It is often missed or ignored or both because of misconceptions and limitations, but we have multiple diagnostic, preventive, and therapeutic modalities which require an integrative approach. Do not miss limb ischemia, do not miss and do not allow amputation. We should try everything in our capacity to salvage the limbs. So thank you so much for listening.
Importance of reversal agents while choosing NOACs. We've been treating patients with vitamin K antagonists, warfarin and acetylcholine for decades. Over the past decade, moved on to NOACs in a lot of these patients. But now this is the new era. Availability of specific reversal agent marks the next phase in anticoagulation care. Dabigatran with idarosizumab is the first and only NOAC with a specific reversal agent. There is this other Endaxanate alpha antidote available for factor 10A inhibitors, but it's not a specific reversal agent. So that's a slight difference. NOACs represent an important advance over vitamin K antagonists in stroke prevention, but less than half of patients who deserve anticoagulation will be actually receiving anticoagulants. Because of the risk of bleeding, which is always playing in the mind of the treating clinicians and the patients. So the availability of a specific reversal agent for the NOACs would improve the confidence of clinicians and patients and encourage use of anticoagulation in these patients. Why do we need to reverse anticoagulation? Often it's in a patient requiring emergency procedure, emergency surgery, like a cardiac intervention or neurosurgery or acute abdomen, or a patient who is experiencing bleeding, life-threatening bleeding like an intracranial bleed or a critical organ bleeding or bleeding in closed space, or there may be trauma or ongoing bleeding despite measures to control the bleeding. Now, idarosizumab is the specific antidote for dabigatran. Dabigatran is available as Pradaxa, and idarosizumab is available as Praxbind. It's an expensive drug, but what the company has done is, if the patient is on Pradaxa and gets bleeding, then it is given free to this patient. That they've done for India, and the cost of the drug is comes to almost a lakh therapy. Idarosizumab is a monoclonal mouse antibody developed with tight dabigatran binding affinity. The FC region of the antibody, which interacts with the immune system, is removed. But the FAB region is the part of the antibody that binds to dabigatran, and that is the active moiety here. Now, this part, this small thing, is dabigatran, and this is idarosizumab. It's a humanized antibody fragment specific to dabigatran, does not reverse heparins or any other anticoagulant. The binding affinity of idarosizumab for dabigatran is 350 times higher than dabigatran to thrombin, resulting in essentially irreversible binding. Ready-to-use solution for IV administration, immediate onset of action, no intrinsic coagulant or anticoagulant activity, no endogenous target, and the idarosizumab dabigatran complex is eliminated quickly within a few hours from body. So this study was done, reverse AD, to study the reversal effects of this drug in patients on active dabigatran. 500 patients in 39 countries, 173 centers. Patients were either in group A of the uncontrolled bleeding cohort or group B as those patients who required emergency surgery or procedure. So the patient were given 5 grams of idarosizumab in 2 doses of 2.5 gram each. It was separated by 15 minutes. The biochemical parameters and hematological parameters were checked, and clinical parameters were looked at. 300 patients in group A cohort, uncontrolled bleeding, and 200 patients in the emergency surgery or procedure. Mean age was around 79, but the wide age range from 24 to right up to 96. And usual comorbidities, congestive heart failure, diabetes, coronary artery disease. One third of the patients were on 150 milligram twice a day dabigatran, two-thirds were on 110 milligram twice a day. And at baseline, the direct thrombin time and ECT were raised as would be expected. So this is the major bleeding event group A cohort, 300 patients. One third of the patients had intracranial hemorrhage, and the next big chunk was 45% patients with GI bleeding. 88% major and life-threatening bleeding, and 38% had hemodynamic instability. Almost a quarter were trauma-related. Of the group B patients, those requiring emergency procedure, most of the procedures were for acute abdomen or bone fracture and cardiovascular interventions. Remember, in an emergency, many patients might not be able to contact the treating cardiologist or neurologist. Now, this is important data. Patients of group A, uncontrolled bleeding, this is direct thrombin time. At baseline, it was around 60 to 70 seconds. But after giving idarosizumab, within minutes, the thrombin time reduced to less than 40, and the effect remains sustained. Same thing in group B patient. The baseline thrombin time was 50 seconds, and within minutes, it was less than 35 to 40. And again, the effect remains sustained. Dabigatran levels, unbound dabigatran. This is a nanogram per ml, 200 nanogram per ml at baseline. And within minutes of giving idarosizumab, it became almost zero, almost undetectable. And this is APTT. It was 70 seconds. And within few minutes of giving idarosizumab, it became less than 40. And the effect again remains sustained. So very effective drug, very effective antidote. We have been using vitamin K antagonists, and we have used injection vitamin K as an antidote for bleeding due to warfarin, etc. But it's a slow drug and not very effective. Here we are seeing the effect of this antidote within minutes. Now, when you're looking at this group A cohort and bleeding, the non-intracranial hemorrhage, that was almost two-thirds. And this was accessible because it was visible bleeding. And this was intracranial hemorrhage, non-accessible, not visible, but CT MRI could be done in this patient. Of this group, majority again were GI bleed and one third were non-GI bleed. Within a median time of 2.5 hours, there was complete bleeding cessation. So patients with uncontrolled bleeding, within 2.5 hours, the bleeding had cessed. For group B, those undergoing procedures, when a procedure was done, and it was assessed by the surgeon or the operator, what was the level of bleeding. After the drug was given, the hemostasis was considered classified as normal in 93% of the patients during the procedure, and in 5% mildly abnormal. And overall median time from first vial to procedure was about 1.6 hours. So this was almost like normal hemostasis after it. So 5 grams of idarosizumab resulted in immediate, complete, sustained reversal of dabigatran anticoagulation. Median time to cessation of accessible extracranial bleeding after reversal in group A was 2.5 hours. And among the surgical or procedure group, it was 6 hours to achieve normal intra hemostasis in almost 93% of group B patients. No safety concern or adverse event. There were a few Indian patients in this reverse AD trial. This is in Delhi, 80-year-old lady was on dabigatran 110 BID. She had presented with fracture neck femur, multiple comorbidities and multiple medications. Patient required urgent surgery. So after admission, when her hemoglobin was like 8.3, idarosizumab was given at 15:40 hours. And surgery could be started at 18:21 hours, so within 3 hours. And it was considered as normal hemostasis by the surgeon. This is another patient from Calcutta, 61-year-old gentleman on dabigatran 150 BID. Prior stroke and systemic embolism, presented with lower GI bleed. It was classified as major bleed, unstable hemodynamics. After admission, idarosizumab was given at 17:35 hours, and the bleeding stopped completely at 2300 hours. That's about 6 hours. But what is important is the bleeding reduced considerably within half an hour of giving idarucizumab. So this is important. There are a couple of case reports in Indian Heart Journal. 79-year-old lady presented with intracranial hemorrhage, was on dabigatran 110 BID, CT scan showed hematoma and sphenoid fracture. Once the drug was given for reversal, the patient improved. CT scan over a period of time, the patient improved and no intervention was required. Now this is interesting. 49-year-old lady had a stroke. She had AF, was on dabigatran 110 BID. There was paresis. She was given idarucizumab within 1 hour of admission and was thrombolized with actualized within 3 hours of symptom onset. And she improved in terms of power. So this was very quick therapy. Patient presented within 30 minutes of symptom onset, was given idarucizumab within 1 hour of admission, and was given actualized within 3 hours of symptom onset. Very quick therapy given. There are other reversal agents, like I said, andexanet alpha. Idarucizumab came into the clinical trials early and was FDA approved in 2015 in India. It's available since 2017. I would say a little later than that, approved in 2017 and was available slightly later. And andexanet alpha FDA approved in 2018, but it's not available in India as of now. A few differences between idarucizumab and andexanet alpha. Like I said, this is specific to dabigatran. It doesn't work on anything else in the body. Andexanet alpha is more general antidote. It targets factor 10A inhibitors like apixaban and rivaroxaban and heparins, unfractionated heparin, LMWH, fondaparinux. This is approved for urgent surgery, life-threatening uncontrolled bleeding. Andexanet alpha, as of now, approved only for life-threatening or uncontrolled bleeding, not for surgery. Idarucizumab is available in our country. It gives immediate, complete, sustained reversal like the data I showed. This requires continuous infusion. There are no safety concerns with idarucizumab. There are some issues with andexanet alpha. No procoagulant or prothrombotic effect with idarucizumab, and transient procoagulant signal. This is some data which has appeared with andexanet. We don't have the full data as yet. Advantage here with idarucizumab, it's a fixed dose, ready to use solution given as a single injection. Here it's a variable dose, lyophilized, needs to be reconstituted, may require bolus plus infusion. So there are few differences between the two. So this is the era of oral anticoagulation with rapidly acting antidotes. We have been, like I said, using vitamin K antagonists for a long time. The next big development was NOACs, which came in about a decade back. And now, over the past couple of years, with the availability of idarucizumab, there is more peace of mind to the treating physician or treating clinician that there is a reversal agent which is effective and quickly acting in case there is bleeding. Like I said, it's expensive. The cost of therapy is almost $1 lakh. But what the company does here is, those patients who are on Pradaxa will get Praxpine free. So that becomes an advantage. Thank you very much, and we'll have questions after the next talk.
Okay, I'm Navi Nanda. My title is Distinguished Professor of Medicine and Cardiovascular Disease, University of Alabama at Birmingham, Alabama in the United States. I'm going to be a talk on left ventricular ejection fraction by echocardiography versus global longitudinal strain in the assessment of left ventricular function. Well, first of all, if you talk about the thing in terms of left ventricular ejection fraction by echo, it has been the cornerstone for evaluating LV systolic function for several decades, despite problems related to image quality, LV shape, and echocardiographer expertise. Ejection fraction is actually a measure of percentage of blood ejected from the left ventricle during contraction. ejection fraction less than 50%, normally it should be 55% or more, but less than 50% confers 10 to 12-fold risk of developing heart failure and 3.5-fold risk of all-cause mortality. So it's really very, very important. Knowledge of left ventricular ejection fraction is critical. For example, we know 50%, half of patients with heart failure die within 5 years. It is also useful in terms of looking at the efficacy of various medications to treat heart failure, like beta blockers, ACE inhibitors, and ARBs. We also know that when the ejection fraction is 35% or less, it may be an indication for ICD or CRT or for having a defibrillator in the heart. We also send patients for cardiac transplantation when the ejection fraction is less than 25%. We also know that certain cardiac deaths, especially arrhythmic, which can occur after infarction, PTC, etc., is related to ejection fraction. On the other hand, very high ejection fraction in the CCU is a poor prognostic sign. So we all know how to use ejection fraction, how to apply it, and how to interpret it. It is part of our daily life, but it is an imprecise, arbitrary method of measuring the severity of disease process. How we do the ejection fractions? One is the visual assessment, eyeballing, which is very accurate in experienced hands. And otherwise, if it's not the person is not experienced, the variability is very high, could be up to 17%. We also use Simpson's method, where we make some geometric assumptions. And now we are also using 3D echocardiography, where you have less assumptions and less inter and intra-observer variability. And it correlates very well with magnetic resonance imaging. And now we also have introduced artificial intelligence based on newer 3D approach, and this is even more accurate. So now we are able, with the 3D echo and artificial intelligence added to that, it's more accurate in the assessment of ejection fraction. What about strain, global longitudinal strain? Strain simply means deformation, and myocardial thickening is a form of deformation. So anytime there is deformation, that's called strain. And I will show you a little bit of a video here. On the right side, you have the LV contracting inwards, and there's a radial strain, but also that's how we measure the ejection fraction, the inward contraction of the ventricle. But then if you look at the next one, which I'm showing with my hand here, the apex actually, the base of the heart here on the top moves towards the apex, which is below here, and that is what is longitudinal strain. How much it moves as compared to the baseline, percentage of that is actually gives you the global longitudinal strain. So let's go to the next one. So basically, what is speckle tracking? Is the strain is measured by speckle tracking echocardiography. Speckle tracking are very small dots, which are due to the interaction of ultrasound and myocardium. They have a specific signature, so the machine can track that particular dot throughout the cardiac cycle and give an idea of the movement of that particular dot, and that is what we call speckle, and that's called speckle, those dots, and that's we call speckle tracking echocardiography. The normal is somewhere, we usually call it about 18% to 20% is normal, but depends on single center studies and core laboratories, and there is a little bit larger range, anywhere from about 16% to 22%, but in general, think in terms of 18 to 20% as normal global strain. We call it minus because it is, the ventricle becomes smaller in systole, so it is plotted below the baseline, so we call it minus. Minus doesn't, so in other words, remember, it's not algebraic subtraction. Remember that minus 26% is better than minus 18%, just to give an example. Well, where is this important? It's important in detection of subclinical diseases, which are very important. For example, early myocardial involvement in hypertensive heart disease, diabetes, systemic sclerosis, etc. These can be detected much before there is a change in ejection fraction, can be detected subclinically by measurement of this global longitudinal strain. It is also helpful to determine distinguish between athlete's heart and hypertrophic cardiomyopathy, which can be a problem. For example, in athlete's heart is healthy and the longitudinal strain would be normal. When it comes to hypertrophic cardiomyopathy, it's abnormal, and therefore there will be decreased longitudinal strain. That's important. Also, amyloidosis, we have found that the strain is actually spared at the apex as compared to the baseline. So when it is spared, when normal strain is given as red, and when it is less red and actually going to white, that means the strain is lower. So amyloidosis, if you look at hypertrophic cardiomyopathy, there's a generalized decrease in strain, longitudinal strain. But when you have amyloidosis, the strain is spared at the apex to give a cherry on top appearance. This sometimes is very useful in detecting patients with amyloidosis, which is actually, we have just found it's much more common than it used to be before. Even in patients with aortic stenosis, they may have actually associated amyloidosis. Now that can be treatable, so that assumes a lot of clinical importance. Also, when it comes to chemotherapy in cancer patients, we know chemotherapy can cause cardiotoxicity, and sometimes the cardiotoxicity can be irreversible if it's not caught early. And here, strain becomes very important, because by the time there's a decrease in the LV ejection fraction because of cardiotoxicity from chemotherapy treatment, strain can pick it up much earlier. So that's very, very important. And if you look at around 15 to 20% decrease in peak global longitudinal strain, that means there is effect of cardiotoxicity, and this actually can occur prior to reduction in LV ejection fraction. So cancer patients on chemotherapy should always look for global longitudinal strain. Once you see a decrease of 15 to 20%, you may have to decrease that the dosage, or may have to change the therapeutic agent. In valvular heart disease also, strain has been found to be useful. For example, in the timing of valvular intervention in asymptomatic patient with preserved left ventricular ejection fraction, the strain goes down even if the ejection fraction is normal. It may be something you may want to think in terms of sending that patient for surgery or for correction in the cardiac catheterization laboratory. And it is also useful prediction of post-surgical LV dysfunction. So valvular heart disease also, strain becomes important. So I think when you think in terms of LV ejection fraction for global longitudinal strain, it's not a question of one competing with each other, because both have their own advantages and disadvantages. To an extent, I think they're complementary to each other, and therefore it is best to use both in clinical practice. For example, in heart failure patients, I think it's always good to look for ejection fraction as well as strain. If you are having patients with diabetes or hypertensive heart disease, which are very common, or asymptomatic coronary heart disease, strain may become more important than ejection fraction, at least to look for subclinical dysfunction. And when you get to clinical dysfunction, at that time, the ejection fraction may lower. So strain may give you an idea of decrease in ejection fraction before there is a change or a reduction in LV ejection fraction. And very important actually is patients with cancer going on chemotherapy. There you should be very careful in looking for strain. Once it decreases, then the cardiotoxicity has started in these patients, and corrective measures can be taken. Thank you very much for your kind attention.